Assalamu alaikum wa rahmatullahi wa barakatuh. This discussion about urinary incontinence, here are clinical cases with their answers. Case number 1, a middle-aged female presents to you the urinary incontinence. What are the important points in the history? By history, you look for risk factors and for details of symptoms. Risk factors such as cough, constipation, hyperity, and difficult deliveries may give us a clue about the diagnosis. The type of incontinence, stress incontinence, which means loss of urine with exertion, such as coughing, lifting heavy objects, whereas urge incontinence, it is the loss of urine with urgency, sudden, strong, irresistible desire to pass urine. There could be also frequency and nocturia. The patient may present with symptoms of a prolapse, for example, lump in the perineum, mass, difficult defecation, and the severity of symptoms is also important. If the patient having symptoms with heavy exertion, this is a mild case, whereas symptoms with severe or strong exertion, for example, lifting heavy objects, this is a mild case. Risk factors here: age, pregnancy, childbirth, menopause, hysterectomy, obesity, and others. All the following are risk factors for developing urinary incontinence. Case number 2, a 45-year-old female presents with involuntary loss of urine on coughing and lifting weight. What are the important points in the examination? You start by general examination, general build of the patient if she's obese, abdominal examination for any masses, any abnormalities. Cough test with the patient lying in dorsal position. You ask her to cough and you observe for any leakage per urethra. The patient should have a full bladder so that this test will be avoided. If the bladder is empty, definitely she will not have leakage of urine with coughing. Vaginal examination for prolapse using a Sims speculum. You look for any signs of vaginal atrophy. If there is menopause with low estrogen, the vaginal epithelium will be very thin and paper-like, and this is risky for developing incontinence. Fistula and pelvic masses also should be evaluated. This is by examination. The Q-tip test. Sterile swab is inserted into the urethra. Ask the patient to do a Valsalva maneuver, for example, straining down, and observe the elevation from the horizontal. If it is more than 30 degrees, this abnormality suggests hypermobile urethra. So here the patient will benefit from surgical fixation here with tape procedure, although this test is not commonly used in practice. Case number 3, a 48-year-old female presents with urinary incontinence. What investigations you will need to send the patient for? The first investigation to be sent is midstream urine examination. We ask the patient to take a sample from the midstream, not from the initial passing urine, because this may contain contamination from the vaginal secretion. To exclude UTI, which is a cause for incontinence. Frequency volume chart. The aim from that chart is to assess whether the patient taking excessive fluid per day. This is the time, oral intake, voided urine, and if any leakage. Some patients have a habit of taking excessive fluid in form of tea, coffee, or water, juices, so that minimizing the fluid intake to the required 2 to 3 liters per day may help to resolve the problem. Pad test, the weight gain of wearing a perineal sanitary towel. If there is difference in the weight after the patient moving for about an hour with a full bladder, this suggests possibility of incontinence. Uroflowmetry, the measurement of urine flow rate in female. If it is less than 15 ml per second on more than one occasion, this is considered as abnormal and indicate either ineffective functioning detrusor muscles or urinary outflow obstruction. Cystometry, it measures the relation between the intravesical pressure, the intra-abdominal pressure, and the detrusor pressure. We get it by subtracting the intra-abdominal from the total intravesical. If there are detrusor contractions, then the diagnosis is detrusor overactivity. Here are the normal values of normal bladder function. Other investigations, for example, cystourethropy, cystoscopy, ultrasound IV, when the patient develops hematuria, recurrent UTI, fistula, and symptoms of dysuria and urgency may be required to reach the diagnosis. Case number 4, a 38-year-old female presents with stress incontinence. She is a smoker and has constipation. Past obstetric history, she is para 3 vaginal deliveries with forceps delivery and planning to have another baby. Cystocele and malrectocele is seen on examination and investigation. General urine exam normal, cystometry no detrusor contractions. So, what is the treatment in this case? From the history, as the patient presents you with stress incontinence and the general urine is normal, cystometry, no detrusor contraction, so the diagnosis is urodynamic stress incontinence. In this case, the treatment, we start by general measures, restriction of fluid intake, reduce caffeine, modifying medication. For example, if the patient is taking diuretics, ask her to change into another type. Treat chronic cough and constipation. These play an important role in the management. The patient not complete her family. You see, she is young age group, so non-surgical therapy is a suitable choice until completing her family. We try with a simple measure, conservative measures, drug can be given until she completes her family, and then we do the surgery. Put in mind that the definitive treatment for urodynamic stress incontinence is surgery, okay? But if the patient, even if she is not completing her family, but she has a severe symptoms, you can do surgery because the incontinence is hygienic and social problem. Non-pharmacological pelvic floor muscle training, Kegel exercise. We educate the patient how to contract her pelvic floor muscles. We start with low frequency, then we increase up to 50 to 60 times per day. The aim to enhance the tone of levator ani, 40 to 60% improvement can be with this exercise. Weighted vaginal cones, gradually increasing the weight to build strength in the levator ani muscles. Maximal electrical stimulation to support the nerve supply to the muscles. Vaginal devices for temporary control of incontinence. Pereniometry, which is a device that gives us a feedback about the improvement in the strength of contractions of the muscles. Pharmacological, we can give duloxetine, which helps to improve the tone of the sphincter. And the definitive treatment for urodynamic stress incontinence is the surgery. Vaginal approach, we have tension-free vaginal tape or transobturator tape. The transobturator tape not involve the risk of a bladder injury that is seen with the tension-free vaginal tape. Anterior colporaphy with Kelly sutures can be done, but the success rate is about 60%, which is lower than the tape procedures where the success rate 90%. Abdominal approach, of course, the vaginal approach is the preferable. Abdominal, Birch colpo suspension and Marshall Marchetti Grants procedures, and laparoscopic procedures can be involved. Case number 5, a 46-year-old female presents with involuntary loss of urine on coughing, lifting heavy weight, no urgency or frequency. Past obstetric history, para 5 vaginal deliveries. She is heavy smoker. The patient is obese, having a cystocele. Cough test is positive. What is the treatment for this case? You see the difference from the previous case is the age. Now this patient, 46 years old, completing her family. So the treatment Also, we start by simple measures because sometimes the incontinence and the whole problem resolved with just these simple measures. Reduce the weight because she's obese, treating UTI, this may be the cause of symptoms, stop smoking, restriction fluid intake, reduce caffeine, modify the medication if she is taking any drugs, treating chronic cough and constipation. The patient completes her family, so surgical therapy is a suitable choice. If we do surgery for the patient and she is not completing her family, the next delivery is by cesarean section to avoid the recurrence of the problem. Non-pharmacological, again, the Kegel exercise is used, and these also non-pharmacological methods. Treatment, drugs, duloxetine, and the surgery the same as the previous case. Case number 6, a 56 years old female presents with frequency, urgency, and nocturia. Past medical history, chronic obstructive pulmonary disease with chronic cough. She is heavy smoker. The patient was obese on examination and had atrophic vaginal epithelium with mild cystosine. General urine revealed 2+ pus cells. What is the treatment for this case? Initially, this patient presents to you with frequency, urgency, and nocturia, so we called it the overactive bladder. If we, based on presentation, this is the overactive bladder. To reach the diagnosis of the Truser overactivity, we should do cystometry and observe the Truser contractions with cystometry. So this patient presents with an overactive bladder. She is menopause, 56 years old. How would you treat her? To start with, simple measures, again, reduce weight, treating urinary tract infection, stop smoking, restriction of fluid intake, reduce caffeine, medication, chronic cough and constipation, all these should be treated. Topical estrogen for 3 weeks may be useful for this woman as she is menopaused, okay? Topical estrogen. The treatment for the Truser overactivity, bladder retraining, instruct the patient to pass urine every half or 1.5 hours, then gradually increase the interval until you achieve an interval of 3 hours or 3 to 4 hours. Drug therapy are effective, imipramine, tolterodine, oxybutynin. The problem here is the side effects and the compliance with the treatment. Desmopressine to reduce urine production, intravesical therapy by administration of botulinum toxin, which causes paralysis of the detrusor pressure muscles and will reduce the detrusor activity. Neuromodulation of the dorsal sacral nerve can be done for those with idiopathic neurogenic detrusor overactivity. Surgery, this is not used routinely and it is only applied for a patient with an intractable disease because of the complications of this surgery. Clamp cystoplasty by taking patch from the ileum, detrusor myectomy, dividing the muscles and then resuturing in the opposite direction, urinary diversion only in severe intractable cases. So the main treatment for detrusor overactivity is medical therapy, whereas for urodynamic stress incontinence, it is surgery. Case number 7, a 60 years old female presents with a frequency, urgency, and nocturia. So again, this is an overactive bladder. Hypertensive and diabetic on oral hyperglycemic drugs. Previous TVT procedure before 10 years for stress incontinence. The patient obese, blood pressure 180/110. She had atrophic vaginal epithelium with cystosine. General urine exam revealed 2+ pus cells. Describe the treatment for this case. We see this patient is old age, 60 years. She is diabetic, hypertensive. Again, you start by simple measures, control diabetes, reduce weight, treating urinary tract infection, stop smoking, and the estrogen is avoided because she is hypertensive and diabetic, although a short topical estrogen, short course, has a minimum systemic effect. Bladder retraining, desmopressine can be given intravesical therapy. Put in mind that the patient has a high blood pressure. So you should avoid the drugs that are not suitable for hypertensive patients. For example, oxybutynin, tolterodine. These are not suitable for cases with heart disease, glaucoma, obstructive urine symptoms, or if the patient having a GIT problem, ulcerative colitis, and so on. Also, should surgery be avoided until control of her medical problem? You should control her diabetes, control her blood pressure, then you can proceed to surgery. Case number 8. This is a 76 years old female present with frequency, urgency, and incontinence on coughing. These are combined presentation, frequency, urgency, in addition to stress incontinence. She is hypertensive, diabetic, obese, and had atrophic vaginal epithelium cystosis. The treatment for this case, first, you should start with the medical treatment for detrusor overactivity. We give general measures, reduce weight, control diabetes, treatment of UTI, stop smoking, and so on. Estrogen is avoided because she's hypertensive and diabetic, although short topical course application may be of benefit for this woman. Bladder retraining can be applied. Desmoprostene can be given. Intravesical therapy to stop detrusor overactivity. Anticholinergic drugs are better to be avoided in elderly patients due to their effects on cognitive function. Because as we know, the elderly patients may have impaired cognition, so these drugs will activate this impairment. So not advised for elderly. Again, because she is hypertensive, better to avoid these drugs. After the control of the detrusor overactivity, so first you treat the detrusor overactivity, then you can treat urodynamic stress incontinence. Because our patient is old age, hypertensive, diabetic, she may be medically unfit, so urethral bulking agent can be given for this patient until the patient get fitness for surgery, or we can repeat this treatment every 9 months to 1 year. So these are temporary measures and used for a tired patient who is not fit for surgery. This is the end of discussion. Thank you so much.